Great. Thanks, Dr. Borman-Shope. So my name is Andrew Olson. I'm a faculty member in hospital medicine and pediatrics, and I have the real honor today of introducing this year's Julia Berg Memorial Lecture. And joined in the room today, I'm joined by Julia's parents. This lecture is sponsored in memorial and remembrance of Julia, who died after a diagnostic error and a missed diagnosis of Epstein-Barr virus-related hepatitis. And since that time, Julia's parents and those of us who have come to know her story and others like Dr. Phil Keyboard from Children's have been passionate to make sure that this does not happen again. Yet diagnostic errors continue to happen, and so we continue to have work to do. So this year's speaker is Dr. Laura Zwaan from the Erasmus Medical Center in Rotterdam in the Netherlands. She's here for the 15th Annual Society to Improve Diagnosis in Medicine Conference that just ended yesterday. And so we're coming off this wonderful international conference. Dr. Zwaan is a cognitive psychologist and epidemiologist who focuses on understanding how we make clinical reasoning decisions, how diagnostic errors happen, and more how to mitigate them and understand what we can learn from doing well. She's a recipient of multiple national, international awards, including the highest award in diagnostic safety, which is the Mark L. Graber Award. So that's an incredible honor, and I'm absolutely delighted. On a personal note, Laura is a friend and collaborator, and I'm super excited to have you here. So take it away, Dr. Zwaan.
Well, thank you for the wonderful introduction, Andrew, and I'm very happy to be here, and I'm also very happy that I get to be here in person and actually meet, welcome, and then in person here. I want to thank you for all you do to improve diagnosis. I had heard about the story of Julia already a long time ago, and it always makes such an impact and really is a reason why we all do this work. So thank you so much for helping everyone learn about this and improve. So what I would like to talk about today is about improving diagnosis in medicine and learning from errors and best practices. The latter is a new research field that I started on recently. Oh, this is the wrong. Oh, has the final slide on. It starts with the end. I have to go back. Sorry, I didn't check that. Great. So what I would like to talk about today is first I will tell you a little bit more about the complexity of the diagnostic process, because it's a really, well, as you all know, a complex endeavor, and I would look at it from the more psychology perspective. And then I would like to talk about learning from errors, which is now called a safety 1 approach, because there's now a safety 2 approach that focuses on learning from things that go well. And I will talk about that after that. So I think most of you know that the burden of diagnostic errors is very heavy. 10 to 15% of the diagnoses are not entirely correct. That doesn't mean that all of those cases are cases as severe as the case of Julia. Luckily, there are a lot of cases in which the treatment was still correct for the misdiagnosis. Sometimes there just was no harm. Sometimes it was just a specification of the diagnosis. But it's still a fairly large number. And the National Academy of Medicine report that came out in 2015 showed that most people will experience a diagnostic error in their lifetime. And many of those are preventable and have high mortality rates. They're also very prevalent in malpractice claims, the most prevalent error type in malpractice claims. So what this does show is that there still is a lot of work to do. And it wasn't until this National Academy of Medicine report that it really started to take off and more attention on this topic was given. And we all wondered why that was, because they're so impactful and they were always behind in comparison to surgical errors or medication errors. But I think one of the main things is really the complexity of diagnostic error. And I will talk about 3 specific items that make it so complex. So the first is a disease evolves over time. The second is the balance of overdiagnosis and underdiagnosis that we have to deal with, and then dealing with uncertainty. Disease evolution. Well, sometimes a disease doesn't really have a an evolution and happens all at once. If there's an accident and people have fractures, that happens all at once. But many of these diseases, they don't. You start healthy, you might have biochemical changes somewhere in your body, genetic predispositions, but they don't have to become diseases. Then there's pre-symptomatic disease, something that will eventually become a disease, but you don't have symptoms yet, so it's tough to diagnose. And then it becomes a symptomatic disease, and this is often where the diagnostic journey starts. But even there, it's often atypical presentations. Disease and symptoms present asynchronously and not all at once, and information becomes available over time from laboratory results. Actually, yesterday, Dr. Olsen has presented a clinical case together with Gurpreet Dhaliwal, and I think that particularly showed how complex it is, and new information comes in and new symptoms start to show up, and it makes it very difficult. And also, not all symptoms are relevant. Some of them you have to ignore and weigh, some you have to weigh higher than others. And luckily, despite all that, still most diagnoses are correct. But there are some risks. In people who are healthy or have maybe biochemical changes that will never be relevant, there's a risk of excessive testing and screening that can result in overdiagnosis. For patients with pre-symptomatic disease, they're hard to distinguish from the two previous categories because they don't have symptoms yet. You do want to find those, so there may be some opportunities for discovery, but we are not there yet. And then there's symptomatic disease. And this is when we often talk about diagnostic errors. There can be a delay by the patient not going to seek care from a healthcare provider. There can also be missed opportunities either by the clinician in the reasoning process or by the system. Time pressure is something that plays a role. Testing could be harmful. Sometimes watchful waiting is better, so not to do too many tests at the front. And then a definitive diagnosis sometimes doesn't alter treatment. So that's all the things that can happen when a patient is symptomatic. And when that goes wrong, that can result in a diagnostic error. Sometimes preventable, sometimes not preventable, sometimes with harm and sometimes without harm. And then there's the second challenge, the balance of overdiagnosis versus underdiagnosis. I already alluded to that a little bit in the previous slide, but this is not only something that is an issue if you don't have symptoms. It is also an issue if you do have symptoms, because you still need to do tests that are relevant. And if you do too many tests, you get still overdiagnosis, and which is that the patient would never benefit from diagnosing this condition. And on the other hand, there's the underdiagnosis because you still don't want to miss it. And this is really, I think, a challenge for a lot of the clinicians in practice. And then there's a third very important challenge that's related to all of those factors, but it's dealing with uncertainty. And I'd like to tell you a little bit about the decision-making under uncertainty from the psychology perspective, with describing an example. Imagine you go to the casino with a group of friends. Well, you walk in and your friend says, hey, would you like a soft drink or would you like some wine today? Well, you think, I'll have a glass of wine. And you get the wine and you continue to the roulette table. Well, you're thinking, what am I going to play? Am I going to go for a color, red or black? Or maybe I feel like I can take some risk today and I'll go for my favorite number. But before you even get to decide, someone on the other side of the table, an elderly obese man, grabs his chest and collapses. And your friend says, oh, you're a doctor. What does he have? Well, this really describes all the three different types of decision-making that we know from psychology. The first one is decision-making under certainty. And this happens when, as a decision maker, you know with certainty the consequences of every alternative. If you pick wine, you know for sure you will get the wine, unless, well, there are of course some situations in which that might not be true, but just assume that you will be able to get that, and a soft drink. You don't know yet how happy you'll be with it. It might not be very good wine, but at least you'll know what you get. Then there's the decision-making under risk. And this happens when a decision maker knows about the probabilities of the outcomes, but you still don't know what outcome you get. So you know that the chances are higher of winning if you go for a color, and lower when you go for a number, but I mean, you can still win when you bet on a number, and you can still lose when you bet on a color. So you don't know what the outcome will be. And then we get to this very difficult one. This is a decision making under uncertainty, when you don't know the probabilities of the various outcomes yet. And I think in this case, you don't even know what all the possible options are, because there are so many. You might think of some cardiac problem right away, but one option that may completely not be considered by a doctor is that the man is faking because he has lost so much. That's another one that you maybe didn't even think about. So yeah, this is really the challenge in medicine. You see this patient, and this is an extreme case of uncertainty because you don't have any information yet, but you might think of a cardiac problem, but also of aorta dissection, pulmonary embolism. You start to identify some maybe factors that you can tell already that increase certain risk of disease, but it is a challenge. And a challenge that also in the ED, also in the hospital department, clinicians have to deal with. And how do they do that? Well, I would like to describe the dual process theory. I think probably many of you know about that already. Daniel Kahneman described this in his book, Thinking Fast and Slow, and identified two different reasoning systems. System one is the heuristic system, and system two is an analytical system. And the system one is the automatic system. It goes fast. You immediately recognize something. Automatic. They say it's everyday decisions and error prone. I don't really agree with that, but I will come back to that later. And system two is slow, conscious, and effortful, and it's said to be more for complex decisions and reliable. So this is to some extent how people cope with this. You use shortcuts in the diagnostic reasoning process to deal with the uncertainty that you have, because you cannot look for every single option. You have to, at some point, make a decision. And there are heuristics that you use for that, availability heuristic. Well, COVID, in the pandemic, of course, everybody was immediately thinking about COVID, and we probably overdiagnosed some things with COVID because there was a positive test and it must be COVID and not look at the other symptoms as much anymore. So when a heuristic fails, then it's called a cognitive bias. So that happens for representativeness heuristic, but also for availability bias. If it turned out not to have been COVID, then we would have called this a cognitive bias. And these cognitive biases happen in doctors. My colleagues from Rotterdam have studied this in, I think, a very nice study that you can actually induce such availability bias in doctors. So what they did was, in the morning, someone from I think it's like similar to the CDC, came to the hospital and told all the residents, it's very important that the information on Wikipedia pages is correct. Because patients look at it more and more and more. So can you review some pages for us? So half of the residents were assigned to look at Q fever, and the other half were looking at Legionnaire's disease. And they provided some updates, read the information, and gave it back to the people from the CDC and said, okay, this is some updates. Said, oh, great, thank you. Then in the afternoon, there was a researcher coming over and said, well, we developed some cases on clinical reasoning that we want to use in education, and we want to get your sense of if the quality is good enough, if this is something that we can use. And they had these people review those cases. And some of those cases, let me see if I have that on the slide. Yes. Some of those cases looked like Q fever and Legionnaire's disease. And they checked, did the people who read this Legionnaire's disease in the morning were more likely to diagnose Legionnaire's disease, and the ones who read Q fever in the morning on a completely unrelated task did that more. And that's indeed what was found. If you were exposed to the Wikipedia page, you would make more errors in towards the disease that you had reviewed. So the case actually wasn't Legionnaire's disease, it wasn't Q fever, but they did diagnose it more often. So that's a real example of availability bias induced in practice when, it was really no link of the two settings. So solutions that have been mentioned to reduce those biases are things like debiasing, be aware about biases, reconsider a diagnosis, and slow down. I don't think this is the right way to go, but I'll get back to that later on. Because I first want to talk a little bit more about safety 1 and safety 2. Up to now, very much most of the work that is done is by learning from errors and near misses. And there's a new area coming up that focuses on learning from things that go well, because that's also a big body of the work that happens that is going surprisingly well. Safety 1 is described as the absence of accidents and incidents. So it focused on reducing the number of errors. The aim is to identify causes and factors to contribute to adverse events and eliminate causes and improve barriers for errors. This is a typical example in that line where you have the Swiss cheese model. There are latent factors that can cause errors in the system. Then there are some active factors when a doctor makes a mistake, doesn't get a lab result back. And then if all of this aligns, then you get such a serious case as what happened with Julia. In research, this is used a lot by looking at patient record reviews and identify cases with errors, analysis of malpractice claims, things like voluntary incident reports. Is all focused on identifying errors and trying to mitigate those by finding barriers that would prevent all of those holes to align in the cheese. It has identified some important risks that we need to work on. It has identified that cognitive causes are a most common cause of diagnostic errors. It has identified, for example, that closing the loop for test results is a really serious problem. Handovers and transitions of care are a very important factor that can contribute to diagnostic error, and many other things have been found that are very important to improving diagnosis. And I'm now looking myself at how it can improve clinical reasoning. We have a project where we look at malpractice claims and try to include those cases in the training for general practitioners, because general practitioners in training, they see a lot of very typical cases. And what these malpractice claims can do is to enrich their knowledge of how diseases present by seeing also some alternative atypical presentations, contexts and settings where things were different maybe from the usual. And I think that is an important way to use error cases to learn from. It can also present like this. You can also have, in very complex settings, you still have to be able to find it, and this can happen. So that's an important way in which we use malpractice claim cases for improving diagnosis. And another very important thing that learning from errors is that it teaches us humility. Everyone can make a mistake. I think that's one thing that these malpractice claims, if you show them to these residents, they think this can happen to me. And that's, I think, so it's not often a case that they would have done right. It's very often a case that they think, oh, in this setting, in this situation, with this presentation, it could have happened to me. And that patients, family, they have a lot of knowledge and experience, and they can contribute to the process. I think that's often visible in malpractice claims, that patients or family have already seen or asked a question that was overlooked. And I think learning from those errors and hearing from also like Julia's story will really bring this to the community, that we have to keep that in mind. But safety 1 only makes us learn from errors. And therefore, we miss a big chunk of the information, and there's a risk for hindsight bias. We did a study on hindsight bias that I want to point out here, where we asked the members, all clinicians from the Society to Improve Diagnosis in Medicine, who are practicing physicians, to participate in a survey. And what we did was we created cases that could be two things, and the chances of those diseases were about 50-50. We tested that in a prior study. So they were approximately equally likely. And the experimental manipulation that we did was that half of those cases ended differently than the other half. The case was the same in content, but for the one, it sort of ended in line with what the doctor was thinking. And the other half ended with, oh, it turned out to be something else. And what we then asked the clinicians to do was to identify the biases that they would identify in the case. You don't have to read all of those biases. These are sort of a couple of the most commonly identified biases. And what we did is we asked the participants to rate whether they thought certain biases had occurred in the case. And the cases had, we did 8 cases with the equally likely probability, sort of 2 similar diseases. So, for example, the case of pneumonia, the case reads exactly the same, but for the one case, it ended with, well, she reported marked improvement in her chest pain and the shortness of breath, as well as the resolution of her fevers and chills, She was instructed to complete her course of antibiotics. So this clinician was on the correct line of thinking. And then in the other half of the participants got this case with, she reported continued chest pain and dyspnea and several episodes of hemoptysis. A CT angiogram was ordered, which demonstrated a pulmonary embolism in her left lower lobe. A heparin drip was started, and the patient was admitted to the hospital. The important thing to know is that the process was exactly the same, only the ending was different. And if we asked the clinicians, do you think this was a diagnostic error? 8% said yes in the consistent case, which is interesting, and 60% said yes in the inconsistent case. And of course, there's a lot of different definitions of diagnostic errors, whether there has to be an error in the process or not, whether it's just the difference between the one disease initially diagnosed versus another. But this gap was quite big. But the most interesting thing is that we found is that if the case was inconsistent with the outcome, they would find many more process errors. They would find many more cognitive biases. All of a sudden, they would see, oh, this was a bias, here was baseline neglect, oh, this was premature closure. Well, of course, this happens in the correct process as well. And this actually doubled in most of the cases. And another interesting additional finding was that they also did not agree at all over what biases happened. The kappa was almost 0. So, which means that it was completely random which cognitive biases they identified. So I would say that debiasing is not the way to go. First of all, I think these biases cannot really be found in the in those cases in a reliable way. And why that is because this process is exactly the same used in cases that go well. And then they're very valuable. If a case goes well, they say, wow, great, efficient thinking. And if it goes wrong, then it's a cognitive bias. And I think that sort of lies the basis for the safety 2 approach. The safety 1 approach shows only those things that go wrong, the unwanted outcomes. And safety 2 looks at everything, the things that went as expected, the things maybe that went better as expected, and sometimes those positive surprises where you think, wow, I didn't think they could get that, and they still did. And then the question is, why do things go right? In the safety 1 approach, we often think, well, something goes wrong because you have a certain procedure and they didn't stick to that. They didn't stick to the procedure. They didn't follow the guidelines or the rules. But that's actually not the case. It very often goes well because the healthcare professionals deviate from it in the situations where you need to. You have to be flexible and you have to adapt to the conditions of work. It's not a straight line. And that's what they identify in the safety 2 approach. They compare work as imagined with work as done. By work as imagined is how supervisors, maybe managers, have outlined how things should happen with rules and procedures and the standards that outline how professionals should work. While work as done is how it actually works in practice. And by comparing those two, you can identify things that go well, maybe things that you can improve on in general, things that you can use. You can find best practices that you can use to improve. Because it's a big difference. The work as imagined is sort of the straight line towards the finish. You think, okay, I'm going to do this step, and then I'll get there. While the work is done, there's a lot of different challenges along the way. And sometimes things that facilitate your process, but sometimes it makes it way, way harder. And despite all that, people are still able to come to this correct diagnosis in most of the time. And it is because we adapt. I will leave this slide for you to read, and I'll take a sip of my water. we can all still read this. And I've used this also to show the opposite of what I'm going to say now, actually, that a computer will give an error when you enter the wrong medication. It says error, I don't know this. A human can still read it. And it can be a risk, of course, at some points. But most of the time, it is helping us, because otherwise we would stand still and will not be efficient. And applying to the diagnostic process, I think the work as imagined in the diagnostic process is like this. The model of the NAM report, when a patient engages with a healthcare system with a health problem, then there's a round of interpretations on the working diagnosis, gathering information, interpreting it, and then communication of the diagnosis, treatment, and outcomes. But in practice, it goes a little bit more like that. And I'm now going to ask you to diagnose 3 images for me. It's going to be fast, so look at it closely. So I think you've diagnosed that there was a beach. Everybody has diagnosed that it was Andrew. And maybe some radiologists have seen that there was a consolidation in the right upper lobe of the X-ray. Radiologists do this within 200 milliseconds, and they're correct 70% of the time. So all this about all the information gathering, there's so much already captured in this first view, in this first look, that is very helpful in the diagnostic process. So yeah, this is the 3 things that you have diagnosed. So I think that's a lot of those things are very powerful, and learning from things that go well and why they go well is therefore important too. So what Safety 2 does, it looks at, aims for as many things as possible go right, and to become understanding of how they usually go right, and to facilitate everyday work. So I will tell you about an example project that we have in the Netherlands that is ongoing on Safety 2, and this was the first time we ever applied. So we just tried to pilot to explore how it works in the diagnostic process, and we did this in the emergency department, because this is really typically complex and adaptive environment where clinicians have to be really resilient, and there's a lot of practice variation for that reason. And it is called action research, which means that we did a cycle of observations and then immediately improved something and did another round of observations. And we included patients of 18 years of older of age and with non-specific symptoms who were at the ED for internal medicine or seen by the emergency physician because they were participating in the study. That was the sole reason. And we excluded consultations from other specialties because then the diagnostic process would have already been fleshed out, and we wanted to follow up on the whole process. And we developed an observation tool that followed the whole process from the pre-announcement, like the patient is coming into the ER, till a treatment plan. And sometimes that took like 2 hours, and sometimes that took like 10 hours to follow the patient. And it was set up in the Dutch healthcare system. And this is what the action research looked like. In the first 1 to 3 weeks, we would do the observations. About 10 to 15 patients were followed in this period of time. There was a resident who's our part of the research team, who actually also attended the conference this year. He was doing the observations and filling all the forms out. And then in the weeks after that, and partly overlapping, additional data was gathered, like what was the final diagnosis, what happened with this patient afterwards. And then we looked at the analysis. We sort of looked at what did we see, what did we find in terms of practice variation was the main thing that we were looking for. What were things that in one case went very differently than in another case? And this was really, we didn't look for inter-rater reliability. It didn't really matter to us if I would find something different than somebody else. But what we wanted to find was things where we thought, there's practice variation. Clinician does it like that, and it seems to go really well, and others seem to struggle and do it very differently. What can we learn from those differences? So we looked for that. And then we had a co-creation session, which I think was the most important thing of the whole project. There were people, stakeholders, coming together in one room and discuss those practice variation findings. There were physicians, nurses, residents, patients, healthcare risk managers. So we had a whole group of people. And what happened there was really wonderful. the first time we started with one of the clinicians, he was, I'm not going to do this. I think this is all, things are going well. I'm not interested. And he turned out like to be the biggest advocate at the end. And I think that's when it turns out to be quite successful, because he was really got into it and discussing how things were going, some things that were going well and how he would do it and how he could spread things better. And he was also willing to learn from others. So that was a good part of the study. What we then do is, in this co-creation session, we would come up with ideas of what are best practices that we want to further distribute in this ER. And we then shared those with all the people in the ER and asked them to make changes. I'll show an example of one of those things later on. And then we would update our observation forms, because we would sometimes have some new ideas of things to include. And we wanted to evaluate the best practices that we implemented. And then we would start over. And we did 3 of those cycles. This is one example of a practice variation that we've seen. So in one internist, for one patient, the internist calls to announce a patient and made a note in the electronic health record with the medical history, diabetes, patient had fatigue, flu-like symptoms, prolonged diarrhea, hypertension, and at the ED, there was anamnesis, physical examination, laboratory, blood gas, urine testing, thorax, and COVID testing. And another one was the internist calls to announce a patient. Patient is struggling with shortness of breath for years. Now one progression since 1 week. Yesterday saturation 98%, no improvement after start, for which referral. And the one made the note in the electronic health record, and the other called. And the residents really felt it made a big difference, because they forgot a lot about the second one. And the first one, because it was a note in the electronic health record that really helped them. And we saw some more practice variations of things that were reported and remembered from the conversation with the clinician who, this was the information that the resident needed about the patient who was going to come in. So this was a reflection of the conversation that an internist, so not the resident himself, had with the general practitioner about the patient coming in. So there's a lot of handover moments there. And if it's not noted down, it can be lost. So in the co-creation session, this was heavily discussed. How should we do this? And the residents were very articulate that they would have really liked to have this in the record, because they could look back if there's a handover to someone else. This information is not getting lost. So that's what we did, and we called it Successful 7. We entered an additional thing in the electronic health record where they could make these notes, and we discussed with all of them what pieces of information should be in there. There was some disagreement there, but we thought, well, as long as we have most of those things listed, this would improve. This would be good for. This would be a good improvement. Another thing I just briefly want to mention that we found is that we observed that the diagnosis was sometimes made earlier when the required laboratory tests were already specified upon arrival. So that was one thing that we also entered then in the Successful 7, because we saw that sometimes nurses would immediately do the laboratories, the lab values, get the urine, the blood samples done while the patient was still in the waiting room. And that really facilitated the diagnostic process, because we also had cases where the patient just went to the bathroom before he got to see the doctor and then had to wait for 3 hours. So this was also something that we thought could go better. And that was the intended diagnostics were then added to the Successful 7, although one of the clinicians said, don't make it a new item because then it will become the Hateful 8. So we added it to one of the other bullets. So our experience is that it works pretty well for the diagnostic process, especially since the diagnostic process is so complex and it is not very structured. And then learning from things that go well is very helpful. And of course, these were very small interventions, were very small improvements, and we haven't measured yet if this actually makes care better, because that's something we still need to figure out. Do you need a lot of extra testing afterwards? Do you find things with overdiagnosis if some things are maybe done too much? But I think getting all these people on board, stimulating positive behavior, at least I can tell in the department where we're doing this, they get really excited about it. They tell each other about it. It becomes a learning culture, which also, I think, stimulates thinking about each other's positive behavior. Thinking like, oh, I see that my coworker does this in a nice way. Maybe we can learn from that. And that's also something that we would really like to achieve, getting the positive learning culture from this. There's some limitations to this approach because it's kind of new, so concepts are not really operationalized yet. There's a lot of different terminology for the same things. Some people say it already exists for a very long time, so it's a little bit unclear. It's also kind of unclear how you should actually measure it. We tried it like this, but this is not in any way an instruction that is being used elsewhere. And of course, system 1 and safety 1 and safety 2 overlap. You cannot only look at things that go well, because you do want to look at the things where the risks are. So that's fine. I think it should, but it's not really always as clear what is safety 1 and what is safety 2. So moving forward, diagnosis remains difficult. It remains complex, and I think that's never going to change. And learning from errors is important. Understanding the risks of the diagnostic process, where are things likely to go wrong, where should we really pay attention? Improving your clinical reasoning skills by practicing, expanding illness scripts that can be from errors, also from normal cases, is to really try to understand how many different ways the disease can be expressed. And humility, very important one to learning from errors. And then learning from things that go well is an important development in diagnostic safety. And I think particularly suitable for a complex process like the diagnostic process. And when I presented this at the Diagnostic Error Conference this week, a lot of people saw many ways where they could implement the learning from things that go well in giving feedback. Even if you look at an error case, you can also find things that went particularly well. And that makes it a little bit easier to talk about and easier to discuss. So I think that was a nice addition that I hadn't thought about, that a lot of people mentioned at the conference. So I'm at the end of my presentation. Thank you so much. And I hope you enjoyed it. Andrew.
Wonderful. Thank you, Dr. Zwaan. So we'll have some questions that come in on the chat. And if you make sure I'll start with one. This idea of learning from positive deviance has been also said that given the fractured health systems we have, and perhaps here in the US even more, it's remarkable it goes as well as it does. Mm-hmm. Can you comment a little bit on that, and then how the safety 2 approach might actually also inform systems fixes that inform best practices that can be implemented?
Mm-hmm. Yeah, I think it's absolutely true that it's fascinating how often it goes well given the complexity of the care. And I think especially if you look at all the different fragments of care, indeed it's a high risk for errors. I think this approach, I mean, we now only looked at the diagnostic process in one ED, but it might actually be much stronger to look at different EDs, different. Yeah, you can compare many different things. You can compare EDs within the Netherlands that are similar, but you can also look at EDs that are internationally different and see how people do things there. And I think in that sense, looking at this practice variation, it really is the strength. See how others do things and what works well, and learn from that.
Great. So another question before we get to the ones that are starting to come in is, I think many of us got into this field and started to think that the role of cognitive bias, it's interesting, it's appealing when you read popular literature, and then you see that it doesn't work. Can you comment a little bit on the evolution of that? You showed some experiments. Can you comment on that over the last few years, and then also our increasing understanding of the role of practice, and as well, like the number of repetitions needed, and how that's how we've learned about learning from some of your other studies?
That's a lot of questions in one. I think
pick one.
As for the cognitive bias part, I think indeed, I think in the field we've put in way too much attention on cognitive bias, because I think indeed the system 1 and the way we can so quickly recognize things based on experience is so good. And we've done multiple studies and tested, like, if you slow down your process, if you rethink, it's not going to get better, because you don't know when. You don't know when you're biased. And since it works very well most of the time, it can actually have a negative effect, because if all of those cases where you did a good job and then you're going to reflect and rethink and reconsider, it might be a problem. So we need to find ways of identifying situations in which we're high risk of making an error, or high risk of being biased, and then try to slow down there, get help there. But that's the problem, because clinicians are not very well calibrated. yeah, what you think often you're right when you're wrong, and sometimes you think it's difficult and you don't know, but you're on the right track. And that's something to improve. Feedback and calibration can really help. And I know Andrew loves the feedback thing. And I think it's crucial. Yesterday, there was a nice presentation at the conference, and they said, they made the analogy of the basketball player, if you cannot see if you scored after you throw, how are you going to improve? And I think that's the same. And I think getting feedback more and more will make you better at estimating when you're correct or wrong, and makes you better in general. And that is a way more important, way more effective solution than debiasing.
Awesome. There's a question here that I think is really from one of our rheumatologists. Could you comment on, there's a lot of clinical practice guidelines that suggest how we should practice, and how, while these are important, they sometimes, the impact on learners, especially when they see someone deviate from that because they feel like the expert may know when to deviate from that guideline. And I think learning, that's a very much a safety to approach, where if you said, well, they deviated from the guideline, but if the outcome's better, it might be because of expertise. Can you comment on that, and then how we may learn from that and use that to inform in the diagnostic process?
Yeah, of course, it's so important that there are guidelines and protocols for certain for certain tasks, but especially in healthcare, they almost never completely fit. And indeed, I think most deviations are probably good. I find it really challenging because you do need the guidelines, but on the other hand, if you also need the deviations from it to be able to adapt. If you look at cases where something went wrong, it's so often said, oh, but they didn't follow protocol. Then I asked, did you look at the protocol? Did you know there was a protocol? And very often the answer is no. So I think, yeah, it's a challenging thing, but I think we should embrace some of those positive deviations and try to encourage doing this in a good way. But I mean, of course, you also need to have you need to have sufficient knowledge and understanding of this. If you don't have it, you can rely probably on the procedures.
Great. We have a question from our Chief Quality Officer. Curious about the role of humility and transparency with our patients and families, including patients, families, and others, especially nurses, as members of the diagnostic team in this diagnostic journey. And can you talk about communication and teamwork and some of those other foundational aspects of things like transparency and humility?
Well, I think open and honest communication for everyone in healthcare is crucial. I think I watched the video that you made of the story of Julia, and I think that's also something that you really appreciated, the open communication afterwards, and that's afterwards when something goes wrong. But I think even during the diagnostic process, open communication about when you don't know something, when something is uncertain, when you have doubts. And for every healthcare professional, I think that's crucial. For nurses, physicians, everyone in the team. You should share uncertainties within the team. You can share uncertainty with patients, and it helps. It helps.
Great. There's a question here about how patient perception of diagnostic error. This says, excellent talk. Is there any data on how patients perceive diagnostic error or experience or report them? Well,
patients look at it, I think, quite differently. I think about the presentation that we've seen yesterday at the conference that Treber Giardina presented. She did a lot of work on how patients look at the diagnostic process and diagnostic errors, and they found sometimes when she compared what patients thought there was a diagnostic error versus when record reviews thought there was a diagnostic error, and it doesn't align very well. Patients see very different things than the clinicians see. I don't know if it has to do with open communication, because some things, if the clinicians would know that something has happened, and patients more often focus on also the communication, they can see something as a diagnostic error. Well, actually, maybe slightly different wording, but it is the same disease. So we've seen that too. Yeah, I think they're complementary, what patients see and what you can find in other sources.
We had some conversation at the meeting as well, just to add to that, about how there's information that only patients can provide that's fundamental, and some increasing work to follow about that. There's another question wondering about the role of creation of a differential diagnosis and how you would approach that from to understand how to make a differential diagnosis and how that helps improve diagnostic performance. And then wondering, is that a system 1 or system 2 intervention? So 2 questions there. How would you design experiment maybe, but then also is that a system 1 or system 2 intervention?
I think making a differential is important because it makes you more aware that other things can also explain the patient's symptoms. So it's good, especially for more junior people, but I think in general for everyone, it would be good to think about what alternative diagnosis could be and make a clear differential. I think actually that might be a system. It was system 1 and system 2, right? It's system 1, system 2, safety 1, safety 2. Very original names for all these categories. But I think it might be a system 2 approach because you have to actually deliberately think about a diagnostic, about alternative diagnosis. So you don't rely on your heuristic system. And actually, I think this might be a pretty good system 2 intervention because it's case specific. A lot of the things that are said about cognitive bias is about rethink again, slow down, reconsider a diagnosis, but it's not very concrete. And this one is a lot more concrete to think about what alternatives you have for this specific case that you should think about. I think it makes it easier to adapt, to notice alternative diagnosis because they're already on your list.
Great. One other question for me, and then we'll go to Dr. Borman-Shope as well, who has a few. Can you comment on the role of time pressure in diagnostic performance? And that's one of the things that's pretty much every conversation I've ever had about diagnosis says, well, just give me more time. Can you comment experimentally, at least, on the role of that?
Yeah. Well, it's of course a major factor. If you don't have enough time, it's not gonna be good. But I can tell you about a study we're running and that you're also involved in, Andrew. We don't know the results yet, so I don't know yet what will come out, but I think it's still a nice hypothesis. In the field of psychology, there was an interesting study that compared objective time pressure with subjective time pressure. So how much time do you actually have and how much time do you feel you have? And they actually found that performance was not very highly correlated with objective time pressure. It was a lot more correlated with subjective time pressure. So the feeling that you don't have time, the feeling that you are rushed was having a lot more a negative effect on performance than the actual time pressure. And they did it very nicely. They gave a decision-making task, and they said to one group that you have enough time for this. And then half of those group, they gave enough time, and the other half, they cut them off after sort of when most people would not be finished yet. And then they also did the alternative. They would say, you don't have enough time. You have to be really quick. And then half of the people, they gave indeed little time. And the other half, they gave a lot of time. And it turned out that what was actually affecting performance was the feeling that you don't have enough time. But we have to see if that's also what we found. So that will be a follow-up outcomes that Andrew will be able to tell you all about, hopefully in a few months.
Perfect. Dr. Borman-Shope.
Thank you so much for being here. I feel like I could probably ask you questions all day. I was intrigued by your emergency department study where the trainees preferred to receive that handoff in written form. And I just wonder if you're digging more into communication preference and if there are generational influences or like patient load influences.
We didn't look into that. I think this was a lot more that they felt in busy settings, they would lose this information. I think it was because there was an additional step of transfer of information. So a general practitioner would call and say, I want to send in this patient, but he would call the internist, and then the internist would have to let the resident know. Sometimes they forgot to let know anything. Sometimes they just made a brief call and said, oh, this patient is coming in with this. And then we showed that there was this best practice that residents were very happy about. This one doctor who would always put it in the record, ask a little bit more questions, I think, too, about like, does this patient wants to be resuscitated? What is the question of the GP? If the GP had, well, I only want to rule out pulmonary embolism. If that's not it, I can do the rest of it or a full workup. And the residents felt like that was I think it was more about the loss of information than about the way the information was communicated in this case.
Right. Yeah, thank you. That those things happen here also. So it's giving me lots to think about. And then yeah, I think a lot about feedback. I know Dr. Olson thinks a lot about feedback. We have done it, I would say, not well, honestly, quite a few times in the residency program, because we got really excited about helping people get better. And I need to let you know that an error was made. And I think a challenge we often face is that, like, who's the best person to give? The ideal, of course, is in real time, thoughtful, protected, with all team members engaged, including the leader of the team being really interested in diagnostic improvement. But we don't seem to have that set up very often. So I'm just wondering about some simple best practices for diagnostic feedback that you've seen that worked well or that we should strive towards.
That's a good question. Well, I think what is important is to get feedback on many cases, not only on the ones that go wrong. Mm-hmm. And it doesn't need to be, we actually recently did a study, and I don't know if this will replicate elsewhere, but we found that it didn't really matter in terms of improving performance, whether there was an explanation of why it was wrong. Just to saying that it was something else, they were incorrect. This was in fourth year medical students, so it's a different group. And they did online looking at x-rays, and then we either give no feedback, or we said, this is the wrong answer, it was this, or we said this was the wrong answer because, and explain everything. And what I thought we would find was that no feedback would be the worst for learning, because then we did another study and we saw how they performed afterwards. And that was true. They were not performing as well, but the ones who got feedback with just saying you were wrong or right did just as well and just as much improved both calibration and performance as the ones who did get feedback, extensive descriptional feedback. So I think in that sense, if that's true, I really don't know if this will replicate it anywhere else. But then by just mentioning, like, oh, this was something else, maybe take a look at how this was presented and why this was the case. It does not need to be an error at all. It can be, of course, an evolving disease. It can have many reasons, but it can help you in terms of enriching your illness script, I think.
I'll ask one more question from the chat as well about the role of AI and specifically decision support tools in aiding diagnosis, and how we, if you could just think about maybe experimentally, but also in practice, how we might start to evaluate how we best incorporate those, especially as it interfaces with our expertise.
Mm-hmm. Yeah, I think there's a lot of promise in the use of AI, because it will give you a content-specific suggestion that maybe you have not yet considered. So I think where with the cognitive biases and rethinking, you don't have anything specific to rethink about because you thought it through already. But AI might give you a concrete alternative example and decision support. We're not there yet, and we have to really think about how it should be implemented. The decision support that provides like a number of suggestions, I think, is already used more and more frequently, like Isabel Healthcare, for example, and that can be helpful to trigger some ideas and indeed think about a broader differential. We're getting, of course, more and more, especially in the more visual specialties, towards really having one answer. And then it becomes very different if I wrote a research proposal on the use of AI tools in dermatology, but then it says like it's cancer, high risk of cancer versus not. It's really tough to say, oh, well, I don't agree with it. It says high risk, but I'm not going to do that, especially, for example, in general practice. So I think there we really need to look into how are you going to implement this to really facilitate the diagnostic process. And it's not a one size fits all, I would say. If you have a lot of expertise, it's very different, and you might be better able to overrule something than when you have less expertise, but the system may be wrong for you more often. And if you have less expertise, like in general practice, that's where you can win, make most of the gains, but they also are very less likely, I think not very likely to overrule the system. And right now it overdiagnoses a lot.
Yeah, we're in our health system, we're rolling out Visual DX, which is a application that can be used for dermatologic diagnosis. And a lot of this conversation has been, where's that going to be most useful? When does it add the most knowledge to the situation? One more question that's come in. I'm curious about your thoughts that there isn't value in slowing down. I've generally felt that taking a quick diagnostic timeout after making diagnosis from system 1 using a quick cross check for system 2. Can you comment on that and some of the foibles with that as a general approach?
Yeah, that's a good question. I actually think mainly that it is not good as a specific intervention because you already do it. I think every doctor, you will never fully rely on your system 1. I think everybody does like a quick check. Did I not miss something? And that's exactly why I think that adding another layer with doing this with the checklist or doing this with, we really now all have to slow down on every case, I think is not gonna work. So it's not like I don't think you should reflect at all. And I think if you feel like you need a timeout, you should totally have a timeout. And if you think like, oh, I need to reconsider this diagnosis, absolutely should be done. But as an intervention with checklists saying, oh, think about what other diseases it can be. Think about if you, all this slowing down, general things are not very helpful in my opinion, on top of what you already do.
And can you just comment, the last question I get, one of the key terms that people in this audience have heard a lot about diagnostic error and clinical reasoning over the years, and some of the world experts, including you. Can you comment on specifically when the literature talks about context specificity? Can you comment on what that means? I think that's a term that's been around a long time, but it's pretty much in every paper now. Can you talk a little bit about what that means and how that informs, especially like that last comment that you made?
The last comment was about
just about slowing down. Yes,
slowing down. Yeah, of course. I mean, every diagnosis is made in a specific context, in a specific diagnosing in one place is very different from diagnosing in another place. And then there's a lot of variation in way patients present. There's a lot of variation in how diseases present. So that makes it very difficult to, you always have to take this content specificity into account. I think that's why we should learn from as many examples as we can see, because that adds to the range of understanding, oh, this can happen in this setting, it can happen, a disease can present this way. So enriching illness scripts, understanding the different contexts and how they influence make a big difference. But that's more like really, the more practice, the better.
Dr. Borman-Shope, do you?
I think we are at time for our virtual audience. Make sure to evaluate today's session. Make sure to log your attendance. Thanks everyone for being here. We will be all virtual next week. And then on November 2nd for the Wanamaker lecture, we will again be offering a hybrid version. So we'll start to see more of that in-person option for those who want to attend that way. Thank you so much to Dr. Zwaan for being here, and to the Berg family for sponsoring many years of outstanding opportunities to learn about diagnosis in medicine.
Session closed.